Good afternoon, everyone. Welcome to our 5th series of case management webinars series with the Nursing Association of Kenya, KMPDU, KCOA, and KMA. I'm going to hand you over to Stella Gathianga, who is our moderator today. Welcome, Stella.
Thanks, Peter. Good afternoon, colleagues. I trust that you're keeping well during this pandemic period and also keeping safe even as you continue offering essential and life-saving health services. I would like to acknowledge our various professional associations represented and appreciate them for enabling these webinars. My name is Stella Githaiga. I'm a registered nurse working at Kenyatta Hospital. I'm also the branch chairperson of the National Nurses Association of Kenya, Kenyatta National Hospital branch. I'd like to welcome you to this 5th edition of the continuing series of COVID-19 case management webinars that happens every Thursday. Today we shall be discussing COVID testing, and our speaker is Mr. Muturi. Mr. Peter Muturi is Mr. Peter Muturi is a public health specialist working with the Washington State University, Global Health Kenya on the influenza program. Mr. Muturi has been among the forefront responders to the Kenya COVID-19 pandemic since the first case was announced in Kenya. He will be taking us through the COVID-19 testing procedures. Thank you. Joined again is one of our panelists, Mr. Solomon Gikundi. Mr. Gikundi will step in for Safari Kifi. The posters had said that Safari Kifi was to be the panelist, but he's away on other assignments. Mr. Solomon Gikundi is a molecular biology specialist with a master's in molecular medicine, currently a laboratory specialist at the National Public Health Lab and at the National Influenza Center. For our participants, I want to again welcome you to this session. For those of you who have any questions, kindly drop them on the Q&A section. Those who have any input and suggestions, kindly put that in the chat section. And hopefully at the end of the presentation, we shall respond. The webinar is CPD accredited. Your CPD points code will be sent to your respective email addresses that you have provided, and then you shall use the code given to upload your CPDs. Once again, welcome to the session. Over to you, Mr. Peter Muturi, so that we can learn about testing. Thank you.
So thank you all, and good afternoon. I'll be taking you on sample collection procedures and also a bit of result interpretation. And to begin with is our objective for this webinar is we need to know what are the types of specimen for COVID-19 testing. We also want to know about the type of tests that are usually done for you to confirm a case of COVID-19. And then finally, I'll take you through the interpretation of COVID-19 tests. Just as a general introduction is that specimen correction, as per the lab, the laboratory contribute vital information about patients' health as well as the care process outcome. And a correct diagnostic and therapeutic decision rely primarily on the accuracy of the lab test results and very importantly on the health of the patient. So in essence, adequate patient's preparation, specimen correction, as well as handling of how these specimens are very, very important for us to get accurate results. And then finally, accuracy of the test results is so much dependent on the integrity of the samples that are collected. And you'll see this later on. I give a case study whereby a sample was collected longly and give us some long results. So COVID-19 science, why do we need to do the testing? Number one is that we need to do the test to confirm whether the patient has COVID infection. And this is important for the patient management decision in our clinical setting. Number two is that we also do COVID testing because we also want to know how many of our people in our communities, in our respective areas have this disease. And this is an example of COVID-19 prevalence studies. We have one that is coming up very, very shortly. Then, of course, we also want to know how many people are dying of COVID-19. And then we also would also like to learn more about the herd immunity in the population. And I also want to say that it is important for us to test for COVID-19 to give us a bigger picture about the public health, and as well as make some mitigations effort in helping investigators to characterize this virus in terms of the prevalence, the spread, and how fast this disease is spreading within our locality. Who are the priority people to be tested for COVID-19? Primarily, if you go around, even in Kenyatta, you go to other hospitals, there's a lot of priority in testing for patients who are already admitted in our hospital with respiratory system symptoms. And even those who have other comorbidities like diabetes, heart disease, and they are not responding well to the disease process, then of course it's very important for you to ascertain whether they have COVID-19. Healthcare workers, it's also advisable for them to, as a priority, to have the test. Of course, you have had cases where our healthcare workers, some of them, I'm sorry to say, they have succumbed to COVID-19. But since they are the first responders, it's very, very important for them to know their status of COVID-19. And possibly something else that you do not know is that there's a lot of emphasis in test security personnel from right away from the police all the way to our armed forces. Of course, that's a security issue. I may not want to continue talking about it, but these security people are also having a priority in terms of testing for COVID-19. Then somehow the truck driver, you have heard about the hurrah about crossing the border from one country to the other. And then of course, some of these truck drivers have also been being tested for COVID-19. And needless to say is that 78% of all the cases that have been tested in Kenya are asymptomatic. And even if you are talking about asymptomatic patients, just remember that these patients, by virtue of them being asymptomatic, they are still able to transmit this infection in our community. And that can really explain why we have an increase in the number of cases that are testing positive in our country. We may talk about the preferred COVID-19 specimen. In the upper respiratory area, we are more concerned about the nasopharyngeal area. That is where the nasal and the pharynx meet. There is also the oropharyngeal area. I'll show up later. And also for some people who are very sensitive noses, sorry to say, a nasal swab can also work. There's a study that was done previously on the comparison between nasal swab and nasopharyngeal swab, and there was some similarity. If you take a nasal swab, you also take a nasopharyngeal swab, the results will always be the same. But for the protocol, from the Ministry of Health protocol, is that you need to combine two, oropharyngeal swab and nasopharyngeal swab in the same viral transport media. And the reason for this is because you also want to increase the viral yield. So when you do the PCR, then you are able to determine whether the patient is COVID positive or not. In the lower respiratory area, and this is particularly for patients who are admitted in our wards, some of them are intubated. You can also get an endotracheal aspirate and test for COVID-19 or a bronchoalveolar lavage, and this can also help you. And then blood, although you have indicated blood there, is more about the serology, especially if you are dealing with, you want to know the prevalence of COVID-19 in our society. That is the only time you can be able to take blood for analysis. Then I have heard that you'll also be doing pathology next week, but it's also very, very important for you to know what type of samples are you going to collect from these bodies in order for you to make a diagnosis of why this patient died. And needless to say, and very, very importantly, is that all samples that are related to COVID-19 need to be handled with a lot of care and ensure that infection prevention and control are always practiced before you you carry out the sample correction. Otherwise, you can end up infecting yourself from the patient. So those are the areas that we correct sample from: the upper respiratory tract area, the nasal cavity, the pharynx, and then the lower area is the trachea and also the lungs. And especially if you're going to do minimally invasive technique for somebody who has died, you can also aspirate from the lungs. And I would also want to say that all the samples for COVID-19 need to be collected by a trained healthcare worker because of the issues of likelihood of you spreading the infection or even infecting yourself. So about testing for COVID-19, there are 3 types of tests that are available for COVID-19. And number 1, which is most of you are more aware about, these are molecular tests or viral tests. There are also antibody tests. This is antibody antigen tests that you can always do, and then not always do. But the major one that is usually done in our labs, like for example, the National Influenza Center, KMPDU, and all these other centers taking or testing for COVID, is actually viral tests. And then the gold standard for COVID-19 is actually for you now growing this virus in the lab, and those are the viral cultures. So what does it mean to have a viral test? It tells you that you have a current infection, which is an acute infection. Antibody tests, which we also call immunoglobulin-based tests, are they show you that you have had an infection in the past. They cannot tell you that you have the current infection, but they tell you, for example, you got infected, you got exposed somewhere in the past, but it cannot indicate the current state of infection. Then of course, we use them mostly in prevalence study. And I told you initially that there is one that is coming up. And they're also very important in contact tracing for those who have been exposed. Viral tests, we normally use what is called PCR testing. That is reverse transcriptase polymerase chain reaction. This is usually a big name there. And for those from the lab, they know all the procedures that are usually done. And I also want to put a caveat here that a negative test does not negate or doesn't give you a possibility that you are negative. It tells you that you don't have this antigen for COVID-19, but it could be that you have a negative test, but you are in early incubation period. There are so many factors that goes into sample testing. For example, how was the sample corrected? Was good material corrected? How was the sample transported to the lab? How was it stored? How was the sample tested? So there are so many factors that can come in if a test is actually negative. And before you prove that it is negative, you must consider as many factors as possible. And then of course, one of the things is we normally correct two samples, two swabs, just like what I've alluded previously. And these are nasopharyngeal and oropharyngeal swab, but in some cases you also correct nasal swab. And this is allowed so that you can be able to increase the viral yield for viral isolation for testing. Majorly, viral testing is the backbone of COVID testing. And this aids in identification of the virus, as well as it's very, very important for the management of patients and also giving us an opportunity to mitigate against the spread of the disease, particularly in a hospital setting, as well as in our community. So when we do the test, we are able to isolate the viral RNA and convert this in DNA so that our machines in terms of PCR can be able to isolate these viruses. We look at the viral test interpretation. When you have a test, and this is very, very important for you as healthcare workers, so that you can talk to the clients and tell them what does it mean to have a positive test. For viral tests, if a patient presents with a positive COVID-19, it means that this person has a current infection and can be able to transmit the infection to others. Of course, you have heard about some terms called CT value, or what is called generally called threshold cycles, which are dependent on the manufacturers. For example, if you are dealing with Roche, they have their own cutoff point or CT value that when you are doing the interpretation of the results that have been obtained by using their machines and also their reagents, this is the CT value. What does it mean? A CT value is a number. For example, it could be ranging from, let's say, 25 all the way to 40. The lower the CT value, the stronger the test. So in essence, for the patient to understand what COVID-19 test is all about, we normally talk about positive or negative. But for us, in terms of science, we are more dependent about the CT value. For example, if a patient has a CT value of about 30, and the cutoff point is actually 35, that means it's a strong positive. And if it is above 35, 37, 38, then it means that this patient has less viruses, particles in their body. And if it goes up, for example, if the cutoff point that is CT value is around 35, and this patient has around 40, then of course the best thing for you to manage this patient is actually to ask for a second sample and you retest that sample. Otherwise, you may label a patient to be negative and yet possibly they have a positive result. So the recommendation for a positive test means that you allow this patient, depending on how they are, if they are asymptomatic, the current practice is you allow them to stay at home, isolate at home, but all the information about this client are passed on to the MOH for their guidance and also for their visit, so that they can take care of them at home. That is what is being advocated in terms of home care for those who are asymptomatic. And then, of course, frequent consultation with the client in case they end up with a respiratory disease is also very, very, very important. What about a negative test? It means that this patient doesn't have, or this person doesn't have active COVID disease. He doesn't have the virus. So what are the recommendations? You let the patient know that they have to continue with the Ministry of Health guidance of social distancing, wearing a mask, and also sanitizing their hands. And in case they develop any respiratory disease, they need to consult a medical person. Antibody tests, like what I said previously, is that if a person has a positive COVID-19 antibody test, this means that this person was exposed to COVID-19 virus in the past. And actually, this usually happens between 2 to around 3 weeks. If you want to do antibody test, you can only do it from possibly the 15th day going forward. And then it does tell you what are the recommendations for this. It tells you that this person needs to protect themselves. And even if they have a positive antibody test, it doesn't confer to them permanent immunity. Nobody knows. These are gray areas. Nobody really knows whether when you end up with a COVID positive results or an infection, that you have a lifelong immunity. So we are still having some gray areas around that, and I think research will reveal more about that. And then the other thing about a negative result, it could mean that, of course, they have never had an infection, but you need to have a caveat about it. They could still be incubating the disease, which possibly have not been able to release enough antibodies into the body. So the recommendations are similar. They still have to use the Ministry of Health guidance in terms of protecting them. Sensitivity about these tests, for example, when you're talking about viral tests, of course, there are issues about how they are more toward healthcare workers support. For example, you have to be there to collect the sample. And then, of course, one of the other things is that although their sensitivity is actually high, but of course, it can also give you some other false positive results. That is, sometimes you may have indeterminate result. Let me say something about indeterminate results. How do you handle this in a clinical setting? When a patient presents with an indeterminate result, there are several factors. One is the way the sample was collected. Two, how the sample was handled in the process, or even how the testing was done in the lab. So how you move around as a clinician is that you request for that sample to be retested again. If the results are still indeterminate, then of course that means that you need to collect another sample for the patient to be tested so that you have a very clear cut. Antibodies require blood, and then of course I've mentioned something about all this. Before you do antibody test, there's that period of waiting for seroconversion to occur. And then the other thing that is also very, very important is that it's very, very important that tell them they're not sure whether they end up with a lifelong protection after they get the infection. And on your screen, I've tried to compare, and I obtained this from a journal, the results that you get for various types of tests that you do. For example, if you're going to do for real-time PCR, which is real-time reverse transcription polymerase chain reaction, of course, it depends on the gene detection. I don't want to go into the area of gene. and is actually, it gives you the results within a very short time. Then, of course, you require sample correction, esophageal, swab, all the others that you have mentioned before. And then the advantages can give you a higher accuracy of results, but again, just remember that it can also give you some false results. Then one of the other thing is, as you correct the sample, you can easily get infected even at the lab level. That's why they are talking about biosafety level 3 or higher when you're doing the analysis. The results, and this is different. You may get some results within 12 to around 48 hours. So the time when you get your results back, it all dependent on the workload, for example, in the lab. If you're doing antibody antigen, then the result you get very, very fast. That means you get it within 10 minutes. If you're going to do a viral culture, it is very tedious. The result may be available to you after almost 10 days. What are the purposes for RT-PCR? Is that you need to confirm the diagnosis, and for antibody antigen tests, that is immunoglobulin tests, you require to know whether there's these disease processes in the community and whether people are getting the herd immunity. And then, of course, for viral, this is the gold standard test for COVID-19, because you'll be able to grow the virus and you know that this person had COVID-19. This is the famous glove. Majority of you know about it. On the left, you can see this is the period of incubation. Then once you incubate, the virus start multiplying in your body. Then you start on day 0. Day 0 is when now you do your test, and the body is still shedding viruses in your body. Initially, you end up with a very high viremia because your body is not able to protect you. The immunity is still very low. Then slowly by slowly, your immunity starts building up. And I must say that this is for an ideal person. If you have a comorbidity, for example, you have diabetes, you have hypertension, you have cancer, this may not really apply to you, because you may end up doing some viral shedding for a longer period of time because your body is still not able to counteract the effects of the antigen. Then from as your body start moving and building up immunity from the 7 for an ideal person, the immunity start climbing up, and then the viral load actually start coming down. So what does this all mean to us? It means that initially, if you need to get a very, very good results for PCR, you have to do this PCR within the past 7 days. That is the one that is represented by the green label. And if you needed to do antibody antigen tests, culture, you can only be very, very successful when the viral load is very, very high. So that means that if the patient starts having symptoms that you think they are for COVID, then the best time for you to do the test for culture is actually the first 72 hours, 3 days. Otherwise, immediately after that, the amount of viruses that you can be able to grow in the lab actually declines. If you need to do the antibody tests, you only can be able to get a very, very good result from day 16, 15, day 16 going forward, because by then the client or the patient has already built up immunity, and you can now be able to fight the immunoglobulins within the body. So what about now the testing? You do the testing on day 0, which is the day that you meet the patient or the patient present to you. And if the resources allow, then you can also do the test again on day 7, day 8, and by around day 14, which is the end of the isolation or the quarantine, if you were to do the test, antigen test, then you find that possibly at that level, the amount of antigen in the body are actually 0 or be very low, so undetectable. But in some cases, you may find there are some people who still end up with viruses. The result still tested positive on day 14. And then you can continue on and find that they are still positive even after day 28. So how do you handle that? From the Ministry of Health guideline that was actually issued a few weeks ago, they are saying that, and this is in recognition of what the WHO has given out, is by day 10, majority of the patients are not actually shedding or are not infectious. So if the resources do not allow, which sometimes can be difficult in terms when you look at it scientifically, for you to be declared to be negative, then of course you need to do a test on the 14th day. That is, you can do one on day 0 and then repeat another test on day 14. And if it is negative, then you can declare that person to have healed from COVID-19. What about if at day 14 you still find that this client has a positive result? Then of course you still need to add another 7 days all the way to day number 21. And on day number 21, you do 2 tests for 24 to 48 hours apart. That means you can start doing your test on either day 20, and then you finish up by day 22 around there. Of course, if we are being told that these patients are non-infectious from day 10, what does it then really mean? Of course, there are some dead remnant of the virus within the body. That is the reason why you are still showing positivity in your result. Personally, I've had somebody who has gone to be positive from day 0 when we tested it the first time, all the way to day number 28. And the person is still in isolation even now because he still needed to do a test and find it negative according to the type of work that he's doing. So what about sample correction? We normally do oropharyngeal swab and also nasopharyngeal swab. From that picture, you can see where we normally go. We usually take the samples from the pharynx. And the essence here is these are the areas that are likely to have the virus before they descend downward into the lungs. And you give some very simple instruction to the patient, ask them to open up their mouth and say, ah, and of course, you'll be able to access the throat very, very easily. For nasopharyngeal, you go through the nasal opening parallel to the palate all the way to the nasopharynx area. As you can see on of course, if you need to do the nasal, you only need to go to the wing of the nose, and you can also get some very good sample. In fact, the comparison that was done previously about the result you get from the nasal is almost similar to what you get with the nasopharyngeal. But you have to follow the protocol from the Ministry of Health in terms of correcting of a sample. One of the other things that is also very important in sample testing is that there's a test that is called RNP test. This is usually done in all the respiratory specimen, not necessarily in COVID. We do it in influenza. Before we test the sample, we have to be certain that this sample came from a human being before it is actually tested. Remember, the resources that go into COVID testing are enormous, then they are huge. So we need to be very, very sure that the sample we are testing is actually from a human being. So, you know the story about samples being corrected from animals. I hope that doesn't come into our testing for COVID-19 in Kenya. Then, how do you reject some of the sample when they find themselves in the lab? One, if the lab gets any undocumented samples, no identification, wrongly labeled, those samples will be rejected just because we are not sure whose sample is that. The other one is spilling samples, those which are leaking out from their container. Most likely they may get contaminated. You have some cases where you have duplicate samples, same samples with the same ID, then of course that's a rejection criterion. Empty viral transport media with the samples. Of course, we would like to have wet samples. Then of course, for example, you have samples which are coming in long medium instead of the clear, crystal clear VTM, they are in a different area. Then finally, samples that are dried, and you cannot be able to isolate the virus. I would also want to share a bit that we have a study that is ongoing. We want to compare the oropharyngeal and nasopharyngeal and saliva. For example, we know that oropharyngeal and nasopharyngeal are very essential for PCR, but assuming to make it easier, and by the way, oropharyngeal and nasopharyngeal are so much dependent on the patient, on the healthcare worker. You have to be there to correct the sample, and that means that you expose the healthcare workers to a lot of pathogens, sometimes with a lot of difficulties, sometimes with bad aiding or poor aiding. So there's a study that is ongoing between University of Nairobi, Washington State University, Global Health Kenya, and other stakeholders to compare the results. We are correcting oropharyngeal swab and nasopharyngeal swab, and then still asking the patient, can you give us a bit of saliva? Then you are able to compare the concordance for this sample after they are testing. And I'm happy to say that saliva is proving to be a good item for sample correction and testing, and possibly in future it may be the only thing that you may require for testing of the COVID-19. But I'm just being hopeful about this. And then of course the other thing is, remember, even with the COVID-19, other diseases are still there, particularly the influenza, and CDC together with Food and Drug Administration, they are trying to come up with a test that can test both influenza A and B as well as COVID-19. And with that, can I be able to end my presentation? Let me see if there are any questions.
Thank you very much, Mr. Muturi. Maybe I can share a couple of questions that are coming in our Q&A section. There's a question about contradicting results. Let me not name the labs mentioned, but two labs have been mentioned. One is private and one is a government lab. And it's something we have seen in the news. What's your take on that? There's also a question about the patient that you mentioned who has turned out positive 28 days later. Would he or she continue with isolation? If yes, for how long? I'd like to add that I've also experienced this. In fact, some of our healthcare professionals who are actually on home-based isolation and who have continued to have a positive test even more than a month later. What is your take on this? Over to you, Mr. Muturi.
Okay, about contradictory results. One of the things that I would like to mention is that we have so many players who are actually preparing reagents, primers that are used in testing for COVID-19. And some of them have different CT value. Well, for example, if you need to interpret our results from this lab, you are going to use, for example, 35. Others may say, if you need to interpret results from our side, you have a cutoff or CT value of about 33. So if I was to get a sample from Lab X who are interpreting their results at 35, and then another one that is interpreting their results at 33, when you look at the two results, they are contradictory because the reagents that they are using and the primers that they are using are actually different. So one of the things that you need to be careful about is that you need to know the CT value for XYZ company when you're interpreting the results. The other thing that is also a problem is that you may get a results, and if it was poorly labeled and there was a problem in terms of documentation, you may get a result that doesn't belong to you. Of course, that is very unlikely because we normally do a lot of documentation and we are very thorough about it. And, but human errors can always occur. Then finally, I would also want to say something about those contradictory results. They could also be about contamination. If there's some contamination within the lab machines that we are using, then of course you get a result that's positive, whereas the result that you're supposed to get was supposed to be negative. But there are so many factors that actually plays out in terms of the results that you get. One of the things is that is the result you are getting below, does it belong to you? That's the first thing. So you need to do a thorough job in terms of documentation. Then there's this patient that you talked about, and I also mentioned about it, who is still positive at day 28. To me, and following up the Ministry of Health and also World Health Organization about the opportunity that this person may not be transmitting the infection after day 10, what could be happening is that whatever the results are coming out could be just showing that he has some remnant dead viruses in the blood. And when you do the test, it is still positive. So in my opinion, I would say that if a patient is still positive on day 28, day 21, or going forward, to me, it's the best thing is, I believe in science, until we get a result that is negative, that's the time that we can be able to say for sure that that person is cured. But for political and other things, then of course, you can always say, you can believe in day 10. But for science, I want to say that you test negative, that is when you don't have the virus.
Thank you, Mr. Muturi, for that comprehensive response. I'll take this opportunity to invite Mr. Gikundi to maybe run a couple of questions because he's also a specialist in the same area. And then we can continue to take maybe another couple of questions as we wind up. Mr. Gikundi?
Yes, I'm on the line.
I know you're also a specialist in lab medicine, and I'm seeing there's quite a number of questions directed towards the discussion that we are having. So maybe you can build up on some of these concerns, the issue of sample contamination and giving wrong results that are not related to the clients. And what is your take? Should such a sample be repeated? Somebody else is asking on COVID certificate, how many days is it valid for? And if the result shows that it is negative, how soon should the client repeat the test? Allow me to also ask a question that a healthcare provider asked me earlier today morning. Somebody working in Bondo who is working in an isolation facility. And he was telling me that they are getting tested weekly as healthcare professionals who are in the front line. And the feeling is that it is becoming a bit too much. What's your take on this? And what are the recommendations for these frontline healthcare professionals? How soon should they be tested, if at all they should be tested? Thank you.
Yeah, so thank you for those questions. Let me first of all appreciate Mr. Muturi for a good presentation. Now, in terms of, so he talked about issues of contamination, maybe as a source of giving what we call maybe discordant results or false positive results. Really, for this one, I would say that the laboratories that are doing the COVID-19 testing, or not only COVID-19 testing, but PCR analysis, they need to know that a molecular test is as good as you make it. So sometimes if you're not careful with your procedures in the lab, you may end up getting the lab contaminated. And so what we actually do, like for us where I am at the NIC, we keep on checking for this. And the way to check for this is maybe doing some frequent swabbing of the lab and then running some tests just to see whether you are picking any background noise. And I think this can be a big problem. It can be a big issue in the labs that are doing this testing. So contamination in a molecular laboratory should be avoided at all costs. Now, there's a question on the COVID-19 certificate. How valid is it? It's valid for like how long? I would say maybe for a period of up to only 2 weeks. So after 2 weeks, then if that is required, then a retest needs to be done. Because the certificate will run, during the period, even if you get a negative COVID-19 certificate today, you can actually get exposed to COVID-19 the same day, even the same day that you are swabbed. So it's important for you to make sure to know that this certificate cannot be kept for a long time and be rendered to be valid. There was a question on if a test is negative, how soon should someone repeat? If a test is negative and this person did not have any symptoms for COVID, then I don't think there's a need for you to repeat the tests unless someone developed some symptoms. The last one was on a concern of weekly testing. I may not want to really get deep into that. I don't know why they chose to be doing weekly testing. For us and for the people who are like very much exposed, like the people who are working in the lab, people who are working in isolation units, we actually taking a test after every 2 weeks, but it is not really very necessary unless you get into deeper issues and you have concerns. Like for me, since COVID started and I've been doing the testing, I've only done 3 tests. Thank you. That's what I may want to say at this point. Thank you.
Thank you so much, Mr. Gikundi. Let me pick a couple of other questions. I see the issue of posthumous testing of people when they've already passed on. Maybe you need to tell us something about it. How valid are these tests and how long can a body test positive after it is certified dead? Number 2, probably mention how many centers we have, testing centers we have around the country. I think by now we probably have gone county, but just for the participants to know how many testing centers are there in the country. Thank you.
Okay, let me start with the one for posthumous testing. So the significance for this is maybe someone has passed on and we are not very sure what this person died from. So that is why we are doing postmortem specimens. Even near the NIC and many other labs, we are handling postmortem specimens. just so that we can ascertain whether this person died of COVID, and so that even the issues of the burial, we may bury this person in accordance. They would take for the body or for the virus to be alive in the body. Once someone has passed on, I may not have a straight answer to that one. So I may want to just leave that for maybe unless someone is doing more work on that, but we have not really delved into that to know how long a dead body can turn positive. Now, in terms of the testing centers, we have I will not give the exact numbers, but we have public health labs. Those are government owned. We have private labs, which are by private institutions. And among the private labs, we have labs that are in hospital setups and others that are in labs that are just conducting COVID testing. I think we may be close to 20 or above 20, but the labs are not spread across all the counties. Like in terms of the counties, maybe I can mention Trans Nzoia, they have a testing center. Uasin Gishu have some testing centers. Kisumu also has some testing centers. Wajir also has some testing center. Machakos and Busia. So, but here in Nairobi, then we have quite a number of concentration of labs. But in terms of the exact numbers, I may not be able to give that because more labs are still being accredited to conduct COVID-19 testing. Thank you.
Thank you so much, Mr. Gikundi. I want to recognize the presence of Dr. Simon Kigondu, who is the General Secretary of Kenya Medical Association.
Secretary
General. Dr. Kigondu, you have something to say?
Thank you very much. I am always pleased to have these sessions, and I want to thank Peter. Peter is from our area, huku Mashinani, and he's the one who took my first COVID test, and ilidunga hiyo nasopharyngeal, and he's actually the one who gave me the lessons on COVID, of which I am an expert. Asante sana, Peter. That was a very good presentation. We want also to thank Solomon for being around and Stella for moderating this session. We want to say that Kenya Medical Association will continue propagating lessons. I think a lot of people are learning from these Thursday 2 to 3 p.m. sessions, and it's a good thing to try to prevent COVID and see how to mitigate what our health workers are facing. Thank you very much, Stella. I think you can continue.
Thank you so much, Dr. Kigondu. I don't know if Mr. Muturi would like to add something, but I'm seeing some of the questions are things that you had discussed earlier. Maybe some people came in late, but Dr. Kigondu says that the session will be available on the KMA website and also on YouTube. We shall also communicate any other way that we can be able to share the full presentation via your emails. I want to repeat again that the session is also CPD accredited, and through your respective regulators, we shall be able to provide a code through your email that you will use to upload your CPD points. The COVID-19 case management series will be continuing next week on Thursday. And next week, we shall also be discussing the same topic on testing. But this time, we shall be hosting our pathologists who work hand in hand with our lab specialists. And we look forward to a very engaging session. I want to take this opportunity to thank each and every one of you for making time to attend this session. I hope you have learned. Personally, I have come out better than I came in. and I hope that I will be able to share the information that we have acquired. Thank you so much to our main speaker, Mr. Muturi. We really appreciate you. Mr. Gikundi, we also thank you for your input. Dr. Kigondu, your KMA team, the clinical officers, our lab officers, and all the professionals represented, our nurses, we really appreciate you for making time. And I just want to end the session by just saying another thank you. Dr. Kigondu, you want to do that thing of yours that you're always doing?
So Peter Muturi, you'll end your show so that Kigondu can take the screenshots.
On behalf of myself and also our Washington State University, I would wish that we continue protecting ourselves as healthcare workers because we are the champions for this. Kaidre, in situations where you find it so difficult, you think that life is very unfair, for example, you get infected, let's not stigmatize our own, or even our own patients. And I'm sure if we are able to do this from our own front, then of course that will be repeated in our community. Thank you so much for listening to me. Thank you, and you're welcome. Bye.
Ole from Kenya Medical Association, thank everybody and have a nice evening. See you next week. We discuss more testing with pathologists. Bye everyone, bye.
Bye everyone from NNAK. Thank you for participating.